Hi, today I'm going to discuss about the basics of ECGs. Actually, this will be benefit for the exams and also for the patient's management. So, basic wave patterns of ECGs P, QRS, and T. The electrical status of the cardiac muscles are indicated by these waves. P wave indicates the depolarization of the atria. QRS complex indicates the depolarization of the ventricles. And the T wave indicates the repolarization of the ventricles. So if a patient's ECG is having this PQRST pattern and regular rhythms, so we can call it as a sinus rhythm. So in an ECG, we have to check the heart rate and the rhythm and the other changes such as ST segment changes and other additional features such as presenting of U waves. If we consider the conduction system of the heart, the initial impulses are generating from the SA node, and from the SA node, which is the pacemaker, the impulses are traveling along the atrial myocytes to the AV node. From the AV node, it is passing through the bundle of His and then along the right bundle branch and the left bundle branch. Actually, the left bundle branch again divided into anterior fascicle and the posterior fascicle. And through these bundle branches, it is end up as the Purkinje fibers to the myocytes. When we are interpreting the ECGs, the calculating the heart rate is very important. So for that, we have to calculate the how many large squares between RR intervals or how many small squares between RR intervals. If we consider the large squares, what we have to do is we have to divide the 300 by the large squares between RR interval. In that case, we can get the heart rate. Or the other way is, if we want to get more accurate heart rate, in that case, what we have to do is we have to divide 1500 by the small squares between RR interval. So with the heart rate, we can know whether there's a bradycardia or tachycardia. Usually the normal heart rate is 60 to 100 beats per minute. Now I'm going to discuss about some important ECG rhythms which are associated with cardiac arrest. During the cardiac arrest time, it is not practical to take 12 lead ECGs because it's an emergency and we are giving CPR. Because of that, we cannot interpret the 12 lead ECGs. So what we are usually doing is the look at the monitor. So in the monitor, we can divide the ECGs rhythms like shockable rhythms or non-shockable rhythms. So according to the rhythms appear in the monitor, we have to treat the patient. If the patient is having just a flat line, so that's called the asystole. So in that case, if the patient is cardiac arrest, that is a non-shockable rhythm. The other non-shockable rhythm is PEA, pulseless electrical activity. Actually, any rhythm with no pulse except the VT or VF, we can call it as PEA or the pulseless electrical activity. Regarding the shockable rhythms, the usually pulseless VT, it can be monomorphic or polymorphic, and also the VF or the ventricular fibrillation. So those are the shockable rhythms. It is really important to identify these rhythms because the early identification, urgent identification can save the patient's life. Some other important tachyarrhythmias except the ventricular tachycardia and ventricular fibrillation are atrial fibrillation and atrial flutter. Identification of atrial fibrillation is easy because it's having an irregular rhythm with irregular baseline. Usually it is having narrow QRS complexes unless associated with bundle branch block. In the physical examination of these patients, you can feel the irregularly irregular pulse in volume and rhythm. If you auscultate, most commonly you may find mitral stenosis. Even in severe mitral regurgitation, atrial fibrillation is a common arrhythmia. Next, the atrial flutter. In the atrial flutter, the rhythm is regular. You can see the RR interval is same. But in between the RR intervals, there is specific pattern of wave which is called sawtooth pattern. So this is the atrial flutter. Then we briefly discuss about the heart blocks. There are mainly three types: first degree, second degree, and third degree. In the first degree, all the impulses conducting through AV node. There is no blockage, but there is a delay. So in the ECG, what we can see is the PR prolongation. If the PR interval is more than 5 small squares, it is considered as prolonged PR interval. If we move to the second degree, there are two types: Morbid's type 1 and Morbid's type 2. In Morbid's type 1, the PR interval is getting prolonged and prolonged gradually, and one is missing. This is called the Wenckebach phenomenon. In Morbid's type 2 also, one P wave is missing after few P waves. But in contrast to Morbid's type 1, the PR interval will be constant or the same duration. Then the third degree heart block, also called the complete heart block. What is happening here is there's no association between the atria and ventricles. So we call it AV dissociation as well. So the P waves is generating on its own rhythm. Meanwhile, the QRS complexes are seen in its own rhythm. There's no association between the P waves and QRS complexes. So in the ECG, if you can locate the QRS complexes at regular phase separately and also the P waves separately, but there's no association, that is AV dissociation or the complete heart block. Then briefly we discuss about the bundle branch blocks. So with a mnemonic called William Marrow, you can remember whether there's a left bundle branch or the right bundle branch block. So you have to consider the lead V1 and lead V6. If you can see W pattern in V1 and M pattern in V6, so that is left bundle branch block. If you can see the opposite, so M pattern in V1 and W pattern in V6, that is right bundle branch block. So easily you can remember with the mnemonic William Marrow. So these are some of the very important ECG patterns you all have to be thorough with as healthcare professionals. That's it for today. We'll meet in another video. Good luck.